Assalamu alaikum, my name is Ibraheem Masoud, and today inshallah we're going to talk about anterior and posterior pituitary gland. So, if this was a live session, I would have asked you how is it and how's it going, but it's recorded, so I'm not expecting interaction. I mean, no people are watching right now, but I'll still ask you questions and focus with me because I'm gonna ask you questions, regardless of this is live or not. So, the hypothesis is also known as the pituitary gland. It's just a fancy saying, okay? Now, if we take a look, if we get a head and cut it in half, what will we see? We will see different structures, but you need to know what does the pituitary gland look like. It looks something like so. Something like that. You got the gland, which is right here, and you got a stalk. And this stalk is known as the infundibulum. It's right above it. So if there's something at a stalk, then it's connecting to something else. What is it connecting to? The hypothalamus. That's exactly what it's connecting to. And it's also sitting on something, right? Because, it's not gonna be held up only, it's gonna sit on something. What does it sit at? What is this bone under it? This is a sphenoid bone, and we call this kind of depression the sella turcica. So on the sphenoid bone, we call it sella turcica, only because of the way it looks, and the sphenoid bone is right here. So if you go from your nose, keep going inside, you will hit a bony structure, and that is your sphenoid bone. It's like a sinus, it has a sinus, and at the other end, which is the inside the cranial cavity or the head, inside your head, there is the pituitary gland. So there is not much here. The anterior, of course, the anterior pituitary and the posterior pituitary, they're different. Different as in different secretions, different origins, but they both do have a role in the hormone physiology for our body. The anterior gland is called the adenohypophysis. So adeno means gland and hypophysis means pituitary, so it literally means pituitary gland. What about the posterior pituitary gland? It's called the neurohypophysis. Why neuro? Because it has some neuro structure in it, because the vesicles come down to the posterior pituitary gland, or rather known as the neurohypophysis, through like fibers, and they act like neurotransmitters sometimes, like ADH, oxytocin. We'll talk more about all this stuff, you will see. And in origin, the origin of the posterior is from the from the brain, and the origin of the anterior, or the adenohypophysis, is from the ectoderm of the nasal cavity. Now we will show more about what do I mean by this. So these pictures, they might look like complicated, but what I needed to know, at some point in your life you were two holes, right? When they say some people didn't evolve beyond that, I mean you were one hole, literally. And then somehow you become like this. You remember from the Dr. Paul, you have this, and then you have this, the notochord and whatever, and the spinal cord, they come out. And this is a fun fact, your brain and your spinal cord, they have holes in it. So your brain is not like all material, it has a hole in it, and it has a hole, and there is a hole connected from it to the spinal cord. So your brain is kind of open from the inside. Not exactly, it's like a small cavity, we call it. Now this cavity in the brain, we call it a ventricle. So we have 4 different ventricles in the brain and the spinal cord. The third one in the brain is called the diencephalon, or the third ventricle, right? So this diencephalon is actually the origin of what? It's not the origin, it gives the formation of something, and that is a neurohypophysis. So look, you see this hole is inside the brain, right? So this material is the brain, this spinal cord. When you grow up, but this ventricle, or this cavity, it's called the diencephalon. That's what it's called. It's neuro stuff, you don't have to know much neuro from now. And then it gives like rise to something, and that is a neurohypophysis. This is why it's called neurohypophysis. What about the adenohypophysis? Can you see the sphenoid bone here? It's cut, right? Why is it cut? Look at this. In your oral cavity and nasal cavity, in the pharynx, it's all connected together, right? So there are ectodermal cells there, and these ectodermal cells will impinge together and kind of like form the adenohypophysis. They will differentiate and grow, and then the sphenoid bone will close, as so. And this is the like invagination from the diencephalon. This was from the oral cavity, the adenohypophysis, and they connect, they make the pituitary gland, and then this is the stalk, and above them is the hypothalamus. This is everything about embryology you need to know. I hope I made it very clear to you. Clear? I hope so. If we do go next, this picture is not required for you, so this is for your information, FYI. Okay, you don't need to know what's happening here, but look at the ventricles. This ventricle is like a cavity inside. So you have the lateral ventricle, we have the third ventricle, because the lateral ventricle is 2, 1, 2, so this is the third one, this is the fourth one. You don't have to know this at all, but this is like for interest because I didn't know what do they mean by diencephalon. So the third ventricle is also known as a diencephalon, and there, like, well, embryologically, it was like this, as I showed you in the previous picture, and this was like your nasal cavity, and the cells, they come out here, and then when they grow, the ventricle stays, okay? But this is the third ventricle, if you ever wonder. You don't need to know it. Now, here's the checkpoint. Oh, by the way, we call this, like the ectoderm, we call it Radke's pouch. So if you get a question in the exam, but this is, I just spoiled you the question. If you get a question in the exam, and you will get a question from the exam, remember what I told you about partitions. Why do you watch them? Because the seniors, they have made the exam, they will tell you what's happening. So I got this question like multiple times. I don't know, I just remember it so many times. Whenever you hear adenohypophysis or anterior pituitary, just remember Radke's pouch, Radke's pouch, Radke's pouch. Always remember it. Radke's pouch from the oral cavity. What is Radke's pouch? It's an ectoderm invagination from the oral cavity. So I spoiled the question basically. The anterior pituitary arises from the Radke's pouch. This is very important. Keep it in mind, please. Never forget it. So if we do go next, we will find more details regarding the adenohypophysis and the neurohypophysis. Notice just how the neurohypophysis is kind of like connected with the brain structure, right? This is the hypothalamus. It has some nuclei. Nuclei is, by the way, is like cell body of the neuron. That's a nuclei. That's literally what it is. So there's fibers coming down. They do store the hormones in the neurohypophysis. I'll tell you more about this in the future slides. So this is just really anatomy. There's not much here I can explain. You can just look and memorize, honestly. So we got here different nuclei. I will tell you the function later on. So as I told you, this stalk is very important. It has a name. It's the infundibulum or pituitary stalk. It looks like a stalk. And then there's the adenohypophysis. There is a neurohypophysis. If you want to remember the adeno A anterior. Although the adeno, like the name itself, is explanatory, so you can just tell neuro is on the back, adeno is in the front, because the oral cavity is in front of your brain, but that's fine. You got some details here like median eminence. This is like important because when I talked about the veins and arteries, some arteries are like found there. We'll talk about them later. You have the infundibular stem, the stem of the infundibulum. So it's a stalk and it has a stem. This stem with the axons and everything. Anterior lobe, it has 3 different parts: pars tubularis, intermedia, and distalis. Like, because tubularis close to the tube, intermedia, it's intermediate, it's not at the end, it's not like close, and this is very far, so it's distal, distalis. These are just ways to memorize them. Honestly, anatomy, just memorize the stuff. You just understand also, yeah, sometimes, but physiology is more understanding. We'll see in the next slide. Again, this is exactly what we saw, and this is in histology. If you need a very easy way to know which one is which, the darker lobe is always the anterior lobe, always. Why? Because it has way more cells than the posterior lobe. And I will show you how many cells the anterior lobe has and how many secretions and how many hormones. It has way more than the posterior lobe. So it's darker. So whenever you see darker, just know it's the anterior lobe. Lighter, posterior lobe. Very easy. And when we differentiate like in very, very, very like differential physiology, sorry, histology, there are some details I'll talk about, but also later. Or this is just introduction. Okay. So I did teach you about some, anatomy and the cross section. So I wanted to look at this and tell me what is this. So what is this? Now, when you see a black area, just know the black area is air. And where would air be in your head? In the sphenoid sinus, right? So inside the sphenoid bone. And what sits on top of the bone? The pituitary gland. What sits above it? This is the stalk, hypothalamus should be, and like that's pretty much everything you need to know. Of course, under it is the nasopharynx, but you won't be asked about it. Just know these 3 structures I told you about: the stalk or infundibulum, hypothalamus. It's above the stalk, and below it, between the stalk and the sphenoid sinus, you will find the hypophysis. That's right. I like it. Now, if we do cut a head from here, don't do it, but I'm saying if we do cut the head from here, remove this cap, okay, the skull cap, and then remove the brain out, cut it out. This man is dead. I'm assuming he's dead. But then we're gonna look at some structures here. Like what? Can you see the optic nerves? 1, 2. Optic nerves, they go from your brain to your eyes. That's how you see. Can you see some arteries here? Can you see the vein? So nerve, artery, vein, nothing new, right? Nerve, optic nerve, internal carotid to supply your brain, and there is a sinus or a vein that drains blood. So why is this important? Like, why do I have to know about this? You see the hypophysis here? In front of the hypophysis, like right here, there, the optic nerve, they kind of come together and form the optic chiasm. So I will draw it in blue, the optic chiasm in blue. Now, whenever, not always, like, but very common question, and you will be asked about this, in not just this block, next maybe like in neuro block, and maybe even in head and neck block. Tumor in the pituitary gland will compress on these structures, and most importantly, the cavernous sinus. How will the patient present with? How will it present? Like, what will happen with the patient? So let's say you see this screen. A patient with bitemporal hemianopia or compression of the cavernous sinus will see the screen without the temporal area, because this is the temple and this is the temporal vision. He will not see it. He will only see in the middle, the nasal area. So, and memorize this like your name. Pituitary gland tumor, optic chiasm compression, bitemporal hemianopia. You will get a question. A 50-year-old man, he has a tumor, he has some problem in hormones. What is one common complication? Bitemporal hemianopia. Why? Because of the compression of the, that's right, the cavernous sinus. Thank you. Let's go next. This is how bitemporal hemianopia. This is the gland, it sits right here, and this is the optic chiasm. You see the optic chiasm, when the gland compresses it, so let's compress, this man cannot see bitemporally. The bitemporal vision is altered, he cannot see the sides. Why? Compressed cavernous sinus, compressed optic chiasm. I made a mistake, don't do the same mistake. Optic chiasm, and he cannot see the temporal area. Now, if we do take a different section of the brain, right, a coronal section, we cut this and we remove the face. What are we looking at? So, what is this? It looks like an onion here, honestly. So what is this? This is the hypophysis, this is the stalk, it goes up to the, this is not the hypothalamus. The hypothalamus is like the whole thing, because now it's cut so you can't see it. What is this? This is our friend. See, this is optic nerve, this is optic nerve. They meet together, they make the optic chiasm. Very important, you have to know it, okay? Now, I'm not sure if Dr. Yaqeen will want you to know about all the nerves, but like, he didn't. Endoripro, we didn't get asked much about the cranial nerves because you will take them in neuro and head and neck. So now it's like very early to know about the nerves. But nerves number 3, 4, and 6, okay? 3, 4, and 6. They're very close to the cavernous sinus and the pituitary gland. So when the gland compresses the optic chiasm, the sinus, and these nerves, the guy will have problems in moving his eyes, because this nerve, it controls all the eye movements except two movements. This movement, which is controlled by the lateral, this movement by the lateral rectus, and this is by the superior oblique. Now these details you don't need to know them. Like, I'm saying stuff, but you don't need to know. But just know 3, 4, 6, they control the eye movements. I think Dr. Hakim told you 6 is lateral, and 4 is like inward and rotation, and 3 is everything else. So when the patient comes to you, can't move his eyes, just know this is also compression of the cavernous sinus and the 3, 4, 6 nerves. You will not get a question in details, so just don't know them in details. Like, I put a slide here, it's extra, you don't need to know. This is a way to memorize superior oblique, trochlear, or like number 4, SO4, LR6, lateral rectus 6, because lateral vision is controlled by what? The 6. This slide is also FYI, you don't need to know it. I put it for you. If you're interested to know, you will get bored of this in a head and neck. So now don't worry about the cranial nerves, okay? Now, again, a coronal section. Let's see if you understood anything. So we said anything that's black, it's air. So this is the sphenoid sinus, ceretorchica. What's this above it? Exactly. I hope you really said this was the optic chiasm, which is above the hypophysis. If you said this was in fundibulum, I'm disappointed, but coronal section, you will see the optic chiasm right above the hypophysis. Know it very well. Why? Bitemporal hemianopia after tumor in hypophysis. Okay, so read the question. I will read it for you. A guy is having a problem with his body hormones. This shows there is a mass in the pituitary gland. So, what structure can it impinge and what other complications? This Dr. Ibraheem even asked you about in the lecture, and he will ask you about it again in the final. I'm sure he will. So, what did we say? Optic chiasm, bitemporal hemianopia. If you did this answer, then you're right. Thank you. Now some veins and arteries. This is kind of important, okay? Like you will not get asked about the details here. I'm telling you, not much details, but you need to know some few details, okay? So first things first, the anterior part of the pituitary gland is not really supplied by arteries. It's mostly supplied by veins. As you can see, the arteries, they mostly go to the posterior part of the gland. So the anterior is mostly supplied by veins, not arteries. Okay. Now we got long veins, short veins, primary plexus, secondary plexus, right here. Why are these important? First, let me just remove the inks and remove everything. Okay. So the hypothalamus will throw hormones into the circulation. Which circulations? The primary plexus. This hypothalamus, primary plexus, hormones will go down through which vein? Long or short? Long, and then secondary plexus, and then to the gland itself. Okay, let's remove this. Now, how do the anterior pituitary respond to that? It will send out hormones to regulate in response to the hypothalamus. But where will it go? It will go to the secondary plexus first, and then through the short veins, then to the primary plexus for negative feedback. Okay? So how does negative feedback happen before the hormones get sent out to circulation? They go from secondary plexus, okay, short portal veins, primary plexus, inhibit the hypothalamus, whatever regulation it's doing. This is very important, okay? So secondary feedback starts from negative feedback starts from secondary plexus, okay? Then go where? Short portal veins, then what? Primary plexus. The opposite, primary plexus, long portal veins, and then short plexus. This is for stimulation, hypothalamus to the pituitary. The rest, like you just know this artery, superior epiphyseal artery, it does supply the posterior part mostly, and the inferior hypophyseal artery, but it's it's right here. Okay, I think everything is covered. They mostly supply the posterior part, mostly. So, what's the function of the long portal veins? That's right, to transport hormones from the hypothalamus to the pituitary. What's the function of short portal veins? That's right, to transport hormones from the pituitary to the hypothalamus for negative feedback. Before the hormones go out to circulation, it just inhibits the hypothalamus. And we will talk more about negative feedback in the physiology part of this lecture. So, let's talk about some tumors. Okay. So, the most common pituitary disorder is tumors, because it's a gland and tumors are just common there. I will not go into details why glands have tumors. You don't need to know why. You will know this in POD, but the most common disorders, just know it's tumors. It's important, and we will see more tumors. So the most common manifestations, I mean, you're having a not you, like the patient will be having a tumor in his head because the pituitary gland is there, so this will impinge other structures. It will cause headache. It will cause visual disturbance. Why visual disturbance? Remember the optic curve and optic chiasm? Exactly. Bitemporal hemianopia. Remember it very well. And of course, it's a gland. If there's a tumor in the gland, then there will be some hormone disturbances. Obviously, hormone disturbances, we don't like that. So, it will happen when there's a tumor. And also it depends on which cell the tumor happens. Most common, like cells that become cancerous are the lactotropes or the prolactin secreting cells. We will talk more about prolactin when we go to the physiology part. So these are two different masses, pituitary adenoma and craniopharyngoma. You will like, okay, these are the same thing. Why did they name them differently? Well, they're not the same thing, my friend. I will show you why they're not the same thing, and you're wrong. I'm sorry, but you're wrong this time. Look, pituitary adenoma, I will show you different pictures to understand. Let's start with craniopharyngoma. I put it first. Craniopharyngoma, first things first, it happens in children, and now I will tell you why it happens in children, and it makes so much sense. So embryologically, we said Radke's pouch is responsible for the gland, right? Anterior gland. Now, the Radke's pouch, it has remnants. These remnants, they sit on the pituitary gland. خلاص, these remnants are done. But sometimes these remnants become cancerous and start dividing, forming a tumor. This tumor will cause problems, the ones I told you about temporal hemianopia, glandular problems, will compress the gland, make it secrete more or secrete less, it depends on what is compressing. It's sitting above the gland. So the origin of the craniopharyngoma is not the gland itself, it's the Radke's pouch remnants. Radke's pouch remnants. Okay? Don't mind my handwriting. Very important, because in the contrary, pituitary adenoma is the gland itself became cancerous, and it happens at any age. This is only children. Why? Because embryologically the Radke's pouch starts being cancerous, so the manifestation will show when the infant becomes a child. You will see craniopharyngoma. So what about pituitary adenoma? It's when the anterior gland, mostly anterior and mostly lactotrophs with a PRL secreting cells. I will talk more about this, don't get confused now. But this is like, the gland itself is cancerous. Here the gland is not cancerous, it's Radke's pouch remnants. Here the gland is cancerous. So we'll find more glandular manifestation and hormone problem in this one than that one. But both like they have like common manifestation as in headache, bitemporal hemianopia, and all that stuff, okay? How do you treat it? As I told you, when you go into your nose, there is the bone, sphenoid bone, and then above this bone is the air or the sinus, and then the sella liturgica, and then the gland. So if you cut through it, simple, right? So we call it transsphenoidal microsurgery because you're going through the sphenoid bone, transsphenoidal. Look at this. You go from the nose, you cut through here, you cut through here, and then you go reach the pituitary gland, remove the tumor part, the cancerous part of the gland, and this patient will be good, inshallah. This is a different picture how it happens. Like, see, it goes through the nose, cut through the sphenoid bone, get the thing out, and of course you have to treat the sphenoid bone after this. Like the sphenoid bone, it has to be repaired, and the dura mater, of course, because you're cutting through brain parts, but you don't need to do all this. Okay, but just know dura mater. This is just in case he gets you, because he said it in his lecture. I reviewed his lecture. He said that the dura mater has to be repaired to prevent CSF leak. You don't know what CSF leak, you don't know what dura mater is. I don't know why, or like why would he expect you to know it, but memorize. Dura mater is like a layer covering the brain, so when you cut through it, you will like get access to whatever is there. CSF is the fluid in the brain, the ventricles we talk about, but you don't need to know this. This is like extra details. Just know transsphenoidal microsurgery. Now the fun part, physiology part. This is everything we're going to talk about. Don't be scared. It's really nice. It's really easy. Like, you can get back to this after we're done with everything. It's like a summary, a picture I got you online. So this is just to review, okay? But this is everything we're going to talk about. As you can see, the neurohypophysis has fibers. It stores. It does not secrete. It stores and then it gets secreted. And here it like synthesizes it and secretes it. Here it just stores it and secretes it. No synthesizing. We'll talk more about the details. Again, this is a table summary for you to go back to it. Now I'm not going to explain it. I'm going to explain them one by one. So we have growth hormone releasing hormone. We have somatostatin, dopamine, CRH, of all this stuff. What are they? They're mostly proteins, by the way. These releasing hormones are in the hypothalamus, because the hypothalamus gets signals from around the body that, oh, we need this type of hormone. And I'll show you more examples in the coming ones. Let's say, for example, someone is hitting puberty now. What will get released? Gonadotropin releasing hormone. Why? Because it will release gonadotropins from the pituitary gland, literally. So what will happen is the GnRH will come out from the hypothalamus, go to the pituitary gland will secrete LH and FSH. See, the problem with this details is that I can't explain if like a table if I didn't explain in details. So we'll come back to this, or you could just go back to this. It's a summary. This again a summary. This is the pituitary gland hormones. Let's actually start with every single hormone that you need to know individually. So this is a pituitary gland. Remember the ventricle I told you about, the third ventricle, where the neurohypophysis comes from? Yes, that's right. There it is. What is this? What is the H for? Hypothalamus. Why? Because it's above the pituitary gland. See how it's formed? And you have a stalk. Stalk here connects to the hypothalamus and everything. And the optic chiasm, our friend. When this grows, it will compress this. Okay, which one is which? I mean, it's written, but like the darker area is the anterior or adenohypophysis. So we have different types, different cells. Somatotropes, they secrete growth hormone. Lactotropes, they secrete prolactin. Corticotropes, they release the ACTH or the cortisol something hormone, adenocortico something hormone. Gonadotrope, they release FSH, LH. Gonadotropes because gonads, FSH, LH, they call it the gonads. Thyrotrope because they release TSH, thyroid stimulating hormone, to the thyroid. So like the names are explanatory, but what you need to know is the color. Why are these acidophils? These are very close in, by the way, like the somatotrope and lactotrope, sorry, the growth hormone and prolactin, they're very close in composition, in like the amino acids. So they do stain acid, acidophil, they like acid, okay? So they stain different. Also look, they have different composition. The ACTH, it has something different than the somatotrope and lactotrope, but it's kind of close to these two, but it's still alone, the family, like the composition of amino acids. So it's basophil. These two are basophils. They have like, look, if you can see here, same composition. This you don't need to know. Know the basophil, acidophil, and all that stuff. The product, it's like literally self-explanatory. We'll talk more about all this stuff. These are the families I told you about. The first family, TSH, FSH, LH, they're very close. They have like the same amino acid, or like very close amino acid composition. ACTH, it's not the same to anything. ACTH is like, it stands alone. It comes from pre-pro-opio-melanocortin, a gene. And this gene, it has different stuff. One of them is ACTH. So it's not like anything else. GH and PRL, they are actually 9 amino acids and they're very close. So 1 to 9 amino acids connecting with each other, and they only differ in one amino acid, the GH and PRL. This information you don't need to really know, do not get asked about them. I just mentioned them for the sake of completion. But what's really important is the coming slide, like the one, the soon slides. This is very important, by the way. This is very, very important. What is tropic and non-tropic? Simply, tropic hormones, they don't go directly to the target organ, rather they go to a gland, then the organ. What about the non-tropic hormones? Notice they don't go to a gland, they go directly to the target organ. Now you say, okay, this is a gland, well, this is the target organ. So like the target organ is a gland, so it's like the final target, you know, the final target. The non-tropic hormones, they go directly to it. The tropic hormones, their final target is after, it comes after, okay? They go to a gland, ideally. Now we know non-tropic and tropic. Now, also notice something else here. Notice how when the hormone is released, like TRH from the hypothalamus comes down to the TSH, okay? The TSH inhibits TRH release, negative feedback. So when A stimulates B, B will inhibit A. You see, A is a good guy, it's stimulating B, it's like giving it a chance to release, but then B inhibits A. Wow, that's bad. It reminds you of someone, right? I'm just kidding. But then B goes to C, and C inhibits B and A. C is the worst of them all. And this is literally just what's happening, negative feedback and all that stuff, right? You can see TRH, TSH, and T3, T4. T3, T4 will inhibit both, TSH will inhibit TRH. That's the way it works. You stimulate something, it will inhibit you. I mean, physiology-wise, it's actually a good thing, because you're doing balance this way. Okay, now the details. So these are some boring details. It's like 191 amino acid, 2 internal disulfide bridge. It's not really very, very important. It's related to peptide genes, prolactin, HPL, not much. This is important. What is it stimulated by? From the hypothalamus growth hormone releasing hormone. Then it will release the growth hormone because it's growth hormone releasing hormone, so it releases growth hormone, right? It says it in the name. As you can see, it's like really close to 2 protein. HPL is human placental glycogen. It's very close. It's from the placenta. This is from the adenohypophysis, and they're very close. I just put this for the sake of completion, but the most important information here is this. Just know this stimulates the growth hormone. Let's talk more about the growth hormone and details. So the growth hormone is released during puberty, and that makes sense. You know, that makes sense when someone hits puberty, he will suddenly get a growth spurt. Why? And that is due to testosterone or estrogen, and these two hormones will release the growth hormone. This growth hormone will then do what? Increase the muscle size, muscle mass, increase the bone density, bone size, make you taller, and it will also do different stuff like activate lipid metabolism and carbohydrate metabolism. How is this relevant? How is it important? Because you're growing, right? So you need to get more energy now. So you metabolize more. That's why in puberty you will metabolize more, because the growth hormone is like really high, and then you're doing more growth, your bones will grow, your muscles will grow. This is also, the growth hormone also comes out in fitness people like bodybuilding. Why? Because you're growing muscles and the bone density increases. How? As I told you. Now I'll show you why. How? Wait, I'm not gonna spoil. No, it's also increased during sleep. That's why they tell you sleep at night, sleep well, because if you want to grow, if you become like taller and whatever, they used to tell us all that stuff. I mean, it's not very false, it is kind of true. You need to sleep at night. Tell your kids like to sleep at night, to sleep well, so the growth hormone can go out and do its actions, make you taller, grow. But if you're short, that doesn't mean you didn't sleep. Don't blame this. I'm sorry, don't blame this, because a big part is also genetics. I'm just kidding. So senescence is also known as like when you get old, let's say 60, 70, why do you start like getting smaller and like they get weaker? Because growth hormone is actually decreased. The muscles are decreasing in size, the bones are decreasing in density and size. So this is how you go. You increase to when you're child, puberty, and then you can decrease when you're older. That's just how it works. You get stronger and then weaker. These are the main actions, and they make so much sense. And now we'll see what stimulates it and what inhibits it. Let's look at this. So growth hormone, stimulating hormone, stimulates the synthesis and secretion of growth hormone. We said this. This is the biochemistry pathway. Remember, GS means stimulate, so adenyl cyclase and PSC. So it's both. GS and GQ both. And the secondary are like CAMP and calcium. This information I'm not gonna ask about. I mean, the doctor's not gonna ask about. Somatostatin is actually very important. It inhibits growth hormone releasing hormone. Wow. Yes, it does. How does it inhibit growth hormone releasing hormone actions? By going to the somatotrope, which is the house for the growth hormone, and stop it. So then the growth hormone releasing hormone will not be able to release the growth hormone. How? GI, inhibitory pathway, CAMP, decrease GH secretion. This is how it happens. So we got a stimulatory and inhibitory. We'll talk more about stimulatory and inhibitory in the coming slides. 1 second. Okay. Let's talk about the stimulating factors and not stimulating factors. So I'm gonna test you on this. Let me test you. Let me think. Glucose is decreased. Growth hormone will go out or not? If you said yes, you're right, because it increases carbohydrate metabolism. You know what? Let me stick to this slide so we show you. Carbohydrate metabolism. Free fatty acid is decreased. Growth hormone is increased or not? Yes, it is. What about exercise? Increase or decrease? Increase. Stress, same thing. Fasting, you need more metabolism, so increase growth hormone. What if you have hyperglycemia? Decrease. What if someone has obesity? Now that's tricky. Obesity means you have more free fatty acid in your blood. This means the growth hormone is what? Not gonna go out, because you already have so many fatty acids, and we said the growth hormone will increase the free fatty acids in the blood. So if you have obesity, less growth hormone. Somatostatin, I mean, we talked about it, obviously in a bit. Senescence, we also talked about it. Pregnancy. In pregnancy, what will happen? Well, look, I mean, you do need metabolism, but in pregnancy, you also don't want to increase the bone growth and muscle growth for the woman, right? Like doesn't make sense. She needs to grow the baby in her like uterus, not herself to grow. So growth hormone will be decreased in pregnancy actually. So you have to just think: do we need to grow and metabolize for our growth now? Someone that exercises, yeah, absolutely. Someone that's obese, no, you don't need to. He has already like too many metabolism stuff. Someone who's fasting, yeah, obviously you need growth hormone. So just think about it this way. And the way it's regulated, so as I told you, the somatostatin, it will inhibit the pituitary somatotropes, to be specific, to just close the gates. Growth hormone, releasing hormone will not be able to stimulate. Now there is also somatomedins. Somatomedins are like insulin growth factors, insulin-like growth factors, something like that. So these proteins are important. Why? Because the liver is responsible for metabolism. When growth hormone goes to the liver, okay, it will tell the liver, okay, now I need metabolism of carbohydrates, fatty acids. The liver will say, oh, okay, let me do the liver for you, 1 second. So this is the liver. Okay, it looks like a liver from knockoff. So this liver will say, oh, okay, growth hormone will come and be like, oh, I need this metabolism. It will increase the metabolism, but also will send back IGF. What will it say about when you A stimulates B, B will inhibit A stimulates B, B will inhibit A. So this from the target tissue, also known as the liver, the bones, the muscles, they will go back and inhibit growth hormone. Okay, they also even inhibit it directly, not just the growth hormone releasing hormone. They also decrease the growth hormone directly. Common sense. This is another chart for you. It's very nice. You can see it increases synthesis stuff. Like these are the actions. We talked about this. Cell number size. This is just basic growth. Increase protein synthesis. Like all of this is just basic stuff. We did talk about it. Now, very interesting question and very common question, and you might get a question about this. What happens if you have decreased GH? So no growth hormone. Short stature, he will not grow. Dwarfism, could be, right? So let's see. There you go, I got them. Why obesity? Why obesity? No GH, less metabolism. We said GH is important for metabolism. So the patient will be mildly obese, a little bit, because there are other factors, but like this might affect his weight. Late puberty, I mean, we said he will not grow, he will not become taller. His puberty will also be further. Why? There is no growth hormone. How do you treat it? We give him GH supplements. If the problem is from the growth hormone itself not going out, then you give growth hormone supplements. Very easy, very simple. Okay, that's why I told you the problem is growth hormone. What about Laron dwarfism? The problem, see, this is a pituitary, okay? It has growth hormone. I mean, this looks like a kidney. This is the pituitary. This is growth hormone. If there is no growth hormone, okay, then we give growth hormone supplements. But what if there is growth hormone, but the problem, the receptor is not there? What do we do now? Supplement will not help in Laron dwarfism. Keep this in mind. Supplements in Laron dwarfism will not help because the problem is the receptors, not the hormone. The hormone is there, but the receptors are not there. Very important. Okay. Wow, that's interesting. What will happen if you have more growth hormone now? What will happen? Think about it. You will grow more. It depends. Let me tell you, it depends. If growth hormone excess happened before puberty, then yes, you will grow more in stature and you will become very, 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 like extremely tall. You will have big hands, feet, tongue, whatever. But if you got, or someone, I mean, God forbid, got the GH excess after puberty, then what will happen? Only his nose, ears, hands, feet will grow. He will get acromegaly. Let's look. So of course it happens through pituitary adenoma. And I told you pituitary adenoma, when the pituitary cells, gland cells, sorry, they start secreting more because they're cancerous. So if it happened in the somatotrope, they become cancerous, they will secrete more GH out of GH. So what will happen? Acromegaly, gigantism. Gigantism means the tall stature I told you about before puberty. But after puberty, you will get like other stuff like feet, organ, hands, growing. Facial features might also be like coarse, cause facial features, too much beard, too much hair, too much many things. This is very important. Why insulin resistance? As I told you, growth hormone increases lipid metabolism, so it will increase the free fatty acids in the blood. What does this remind you of? Insulin resistance, type 2 diabetes, so they will have that. What else? Hyperglycemia? Oh, there it is. Why glucose intolerance? Because they also increase the metabolism of, that's right, carbohydrates. So you will have too much glucose, hyperglycemia, so this will be mostly diabetic. Okay. Hypopituitarism. Okay, this is important. Let's look at that. Let me go one by one. Pituitary gland, what if it all gets cut off? This is impossible, right? Well, what if the blood supply gets cut off? Well, you have it. This is Sheehan syndrome. From bleeding, there will be infarction in the gland. So let's say you have this much blood in your body. From bleeding after pregnancy, you will have only this much blood, less. So there will be low perfusion to the gland, hence infarction. Infarction means the death of the tissue. So this will happen in Sheehan syndrome. And what will happen? No prolactin. So let's put here no prolactin. Remember, prolactin is in the gland, so now no prolactin. No menstruation. Why? Because LH and FSH are not there. Cold intolerance? Yes. Why? Because thyroid hormones, the TSH. So this is from TSH, because remember, the thyroid, they make us more heated. This thyroid hormone is less heated. So now cold intolerance. Absent menstruation, that's LH, FSH and LH. Okay, FSH and LH. Failure to lactate, that's prolactin. All of these are hormones at the pituitary. Imagine you got the supply, gone. What about pituitary apoplexy? Hemorrhage of the pituitary gland, so also bleeding, and it usually happens like from adenoma, like this tumor, it grows too much, it starts to bleed, or like maybe trauma. This all can cause the bleeding of the pituitary gland. All happen, same presentation. So of course you will get severe headache. Remember, bitemporal hemianopia because of pituitary adenoma, visual impairment, same thing, optic chiasm. How do you treat it? You give hormones. So for this one, you treat the surgery, you treat the tumor, you see if there's a problem, because now when you remove it, there is hypopituitarism, you give hormones. Here, same thing. You have deficiency, you give hormones. Prolactin. Boring details, but notice how it's close to the growth hormone. It's very close, but boring details. No need for all this. Now, some books say prolactin releasing hormone, some books say thyroid releasing hormone, but your doctor said thyroid releasing hormone goes from the hypothalamus to the pituitary gland and releases prolactin, increases prolactin secretion and transcription. But there is something that inhibits that, and that is dopamine. Dopamine is the opposite of TRH. So if TRH stimulates secretion and transcription, this inhibits secretion and transcription. Very simple. So one of the functions, prolactin is very important for what? Milk production is also known as lactogenesis. So to make milk, to develop the breast gland, breast tissue, because, and when does that come out, by the way? When does it come out? It comes out during pregnancy and during childbirth, all of this. So increase during pregnancy and lactation, when the woman needs to breastfeed her baby. Inhibit ovulation, that makes sense, right? Why? Because breastfeeding, so there is no menstrual cycle, and also during pregnancy, no menstrual cycle. Why? Because of prolactin. In males, if there is excess prolactin, of course, it's not good, so it will inhibit spermatogenesis and cause infertility. Why? Because just know this rule: PRL inhibits gonadotropin releasing hormone. So imagine males have no gonadotropin releasing hormone because of a problem in PRL, which is pituitary adenoma, by the way. What will happen? Infertility, no spermatogenesis. For women, same thing. They will excess milk production, excess breast development, the gland. They will have excess lactation. They will have no ovulation, messed up menstrual cycle. They will also have infertility. So you just think about the hormone actions and what will happen if you stimulate it or inhibit it. Just think that way. So prolactin, inhibits GnRH if we have it in males, and what I mean, if you have excess in males, what will happen? Infertility. Good, good. So, oh, also one more thing. How in pregnancy prolactin increases, but there's no breastfeeding in pregnancy? How is that maintained? If you're smart, you would have said progesterone. I mean, you're smart, but like if you know this information, progesterone, it inhibits the actions of prolactin. Okay, this is very important. So after pregnancy, when the baby is out, progesterone and estrogen, they go down, prolactin is there. So now progesterone is not inhibiting the actions of prolactin. Prolactin will start immediately producing milk, and that is why breastfeeding comes after pregnancy, not before. Before, just remember, this hormone inhibits prolactin actions. Good, good. Again, the pathway, you know, this inhibits, this stimulates. What happens? You'll be like, oh, Ibrahim, you tricked us. This is stimulating. Well, yes, this is a positive feedback, because as long as there is prolactin, and when does prolactin come out? When there's a baby, right? When there's a baby, you always will need more. Until there is no breastfeeding, you will stop. Dopamine will decrease that. So this is one of the positive feedback, actually. Okay, one of the few positive feedback. But this also, by the way, positive feedback. One second. Yeah, sometimes the positive feedback, like, it also has negative feedback. Like the prolactin, it goes to the hypothalamus, increase dopamine, TRH. It depends. It depends on the time, really. Like if there is a baby, then the TRH will take over. If there is no, then the dopamine will take over. It's just about the balance and the levels. Because remember, the suckling reflex and all that stuff, it increases the milk production. It will ask for more. I just said it. So suckling reflex will increase prolactin, inhibits dopamine. So during like breastfeeding, dopamine actions are suppressed, prolactin actions are high, TRH actions are higher. So dopamine is suppressed, quiet. TRH, that's right, stimulates. Dopamine antagonists. What does that mean? So if something inhibits dopamine, dopamine will shut up. And what will happen if dopamine is not inhibiting? Prolactin is out. Pregnancy, we said, stimulates it, but progesterone inhibits its actions. So estrogen will increase prolactin, but progesterone will inhibit the actions. So the actions will take place after pregnancy, but prolactin is there during pregnancy. Sleep, stress, they increase prolactin, not very important. What do inhibit? The dopamine, the agonists, somatostatin, prolactin. As I told you, this one might look confusing. It's both. It's kind of both. It depends on like other factors, but like mainly prolactin will stimulate the hypothalamus to send dopamine to inhibit the anterior pituitary, but sometimes you need more, so the suckling reflex and all that stuff will increase the TRH. So yes, prolactin is negative feedback, not positive. No, positive is suckling reflex and that stuff. This is negative feedback. Look, dopamine. Okay, I'm sorry, I messed up something. Okay, all good. Somatostatin inhibits, we know all that stuff. Okay. What will happen if there is excess? I told you, there is excess. Galactorrhea means you have excess milk production. Infertility, no GnRH. See, I'm going quickly because I explained all that. Why would it happen? Either failure of the hypothalamus to inhibit prolactin, or prolactinoma, pituitary adenoma in the prolactin secreting cells, which are the lactotropes. That's right. How do you treat it? You give something called bromocriptine, which is a dopamine agonist. So it is pro-dopamine. And what does dopamine do? That's right, it inhibits prolactin. Good, good, very good. Again, this cycle. So pregnancy, everything increases prolactin, but progesterone, it stops the actions until pregnancy happens and breastfeeding is required. This is what we talked about. See, when you hear baby crying, or like cooing, or just a smell, sometimes it produces prolactin, subhanallah. Suckling reflex, like stuff related to breastfeeding. You will know, yeah, your body will know that it needs prolactin. As a female, of course, not men, alhamdulillah. Hormones, posterior lobe. What are the hormones in the posterior lobe? Two, just two. ADH and oxytocin. Okay. What do they do? Let's talk about them. So, this slide is very simplified, very simplified, like extremely simplified. Okay. So, antidiuretic hormone, it does what? Just give me a second here. Okay. So, antidiuretic hormone, it does what? It gets water from the distal tubules and collecting ducts in the kidney to the body. So it goes, this ADH, it goes to the kidney, be like, oh, hello kidney, this tubule, I need to add some stuff there. What does it add? Aquaporins. These aquaporins, they absorb more water. So whenever there is ADH, you absorb more water to the body. Why would you absorb more water? Because obviously you don't want to waste the water. You might need it. Maybe there is something. We'll talk about the stimulating and inhibiting factors of antidiuretic hormone. This is low yield. It's sometimes acting neurotransmitter. I told you because it's a neurohypothesis, but kind of low yield. Reduces your urine. It makes sense because you're taking water away. If there is less water in urine, so that's less urine. I mean, that's very easy and simple to understand. Labor contractions in oxytocin. So first, what does oxytocin do? Oxytocin, it's responsible for the labor contractions. Labor, what is labor? When childbirth, okay? So when a woman is doing labor, childbirth, I mean, the uterus will be stressed. When the uterus is stressed, now this is the positive feedback I need to know. This is the only positive feedback, and it's very important. When the uterus is stressed, the muscles, this will send through nerves to the hypothalamus to start releasing oxytocin. The hypothalamus will talk to the posterior pituitary and be like, oh, oxytocin, go out. Oxytocin will go, start stretching and contracting the uterus even more. The uterus, because it's contracting and getting stressed more, what will happen? It will get excited and send again to the hypothalamus to release more oxytocin. More oxytocin, again, it keeps happening until the baby is out. When the baby is out, the uterus is no longer contraction, no contraction anymore. Oxytocin will not need to be there, it will go down. It's also important in lactation. So this is different from lactogenesis. Lactogenesis is the production of milk. Lactation is the ejection of milk. So this is the breast. The ejection, there are like muscles here around the duct. So let's zoom in. This is the duct. These are some muscles. Okay, the myoepithelial cells, and this is the milk. Oxytocin stimulates these muscles to push the milk out through the nipple. That's how it happens. So oxytocin for milk ejection, prolactin for milk production. Be very careful with this. Seriously, the small details, be very careful with it. Emotional bonding and sperm transport. This is these are like other stuff. I don't think they're sure if it does happen, but it like kind of makes sense for them. But these two above are most important. Lactation, labor contraction, very important. Again, I don't like this table. What you need to know is that they have 9 amino acids. Like you don't even need to know this. You need to know the source though. Look, the source. Remember what I told you about the nerves here? The nerves here, 1, 2, the cell bodies. So we have 2 cell bodies, one supraoptic and one paraventricular. You know what? I have a slide for it. I'll tell you in the next slide. These are the functions I told you about. So smooth muscle cells, pregnant uterus, and milk ejection. This is water absorption increase. So I told you all about that. I will tell you more about the paraventricular and supraoptic in the next slides, inshallah. So this is a neurohypophysis. Notice that it doesn't look like an adenohypophysis. Adenohypophysis is darker and it's like more glandular in looks. This is not glandular. Here you can see the capillaries. You can see some cell bodies. You can see some like axon-like structures. It's like more neuro. Now don't get that to know what you're looking at. You don't know what you're looking at. So you're listening to me to know what you're looking at. I'm just kidding. So here we have like in detail. So these are different stains, different pictures. We have herring bodies. So 1 second. We have herring bodies. Herring bodies are dilation of an axon. So you remember this nerve? Wait, let me draw you a nice nerve. These are dendrites, cell body. This is the axon, right? So this axon gets dilated, it makes this herring body. So the dilation of the axon is just herring body. That's what it is. Cap, it's capillaries. Pituicytes are like the pituitary cell itself, the structure of it. Pituicytes. Capillaries, they look reddish. Herring bodies again, they're dilation of axons. Pituicytes here, not much. Very easy. Now you know what you're talking about. Now you are pro. Now you can easily identify. If you go back, you can easily tell, oh, these are pituicytes, some herring bodies here and there. Now you're professional at it, mashallah. So, posterior lobe hormones. Again, we have oxytocin. I told you I will tell you about paraventricular nuclei. I didn't lie to you. I will tell you about it. So, oxytocin comes out from the paraventricular nuclei, ADH from the supraoptic nuclei. There isn't much to explain here. It's self-explanatory, very easy. Like just memorize it honestly. Supraoptic, if you want a way. So A is superior. So supra, A supra, because everyone likes A. ADH. Oxytocin. I mean it's the OP, O and P. Like they close. This is just a way I used to memorize this. I really doubt they will ask you about like which one does this, which one does that. But if you want to memorize, just remember OP, oxytocin paraventricular, ADH supraoptic nuclei. So this means they're sensitized in the hypothalamus and stored in the posterior pituitary. Okay, they both contain 9 amino acids, and this is important. Okay, look, pre-pro hormone or pre-pro-presovicin. This is a pre-pro hormone. So after it's cleaved, it will get you a single peptide, ADH, neurophysin 2, and a glycoprotein. You should have taken this in physiology, and then like the actual physiology of the pituitary hormones. This is more like anatomy and a little bit of physiology. So you should take this in physiology, but if not, again, A2 doesn't make sense. It doesn't. Memorize it. A2. Why A2? Because A is number 1, this is number 2. Now this is I always remember like 1 with 2, and then 2. Remember this is the less superior one, oxytocin, with 1. So you like mix and match. That's just my way. If it's confusing, don't memorize it my way. Memorize it your own way. But this is pre-pro-oxyphysin. It will yield this, and that. How is this important? Sometimes they measure the neurophysin 1 and 2, and they see if ADH is out or like oxytocin is out. Simply that's it. So, recap: ADH supraoptic and neurophysin 2, oxytocin paraventricular, neurophysin 1, OP1, A superior 2. Memorize the whole slide this way. It's up to you though. That's just my way. I'm sharing it. Of course, how does it happen? Pre-pro hormone, just like anything. Pre-pro hormone from the Golgi apparatus, it will be cleaved to pro hormone, then it goes to the hypothalamic hypophyseal tract, goes down to the posterior pituitary. In the secretory vesicles, the secretory vesicles will cut the pro hormone, make it a hormone, and then secrete it into the circulation. Very simple. It's like we've been taking this for a while now. So Golgi pre-pro, cut the pro hormone only. Pro hormone will go through the tract. Pro hormone will reach the posterior pituitary. Pro hormone will be inside the secretory vesicles, and then the hormone will be separated from the pro part and be secreted. Easy, right? Okay. So I was supposed to draw here, but I did tell you about like the pre-pro hormone. So the secretory vesicles, it's like this. It has the pre-pro hormone and all that stuff. Whenever it's stimulated, it will release it into the circulation. Now how? I'll tell you what. 1 second. So again, I will just draw this down. Secretory vesicle. Remember ADH, neurophysin 2, and the glycoprotein. It's in the vesicle. How is it stimulated? How is it released? Calcium. Why? Remember, calcium has a special relationship with the secretory vesicle. So calcium will come, get the secretory vesicle out, and then into circulation. How is calcium getting it out? We go back to the action potential and all that stuff. So the nerve will bring the signal to the hypothalamus, action potential, depolarize, sodium comes in, open the calcium comes in, calcium gets the physical out. You know this. Even if you don't need to know it really. I just put this like for the sake of completion, honestly. And then trace the target tissue. So this is not very important. As I explained, pre-pro, then the pro will go to the secretory vesicle and be separated to only one. So oxytocin with neurophysin 1, and then when calcium comes in, this will go out and it will go to the target tissue. Same thing here, target tissue, sorry. Now, ADH regulation. How to regulate antidiuretic hormone. By the way, ADH is antidiuretic hormone. Diuretic means to secrete water into the urine, so more water into urine. That's diuresis. So antidiuretic hormone means you absorb water instead of keep this in mind. So antidiuretic hormone means absorb water. So, how is it regulated? Let me explain something. Okay, let me draw here. This has this much water. and this much electrolytes. This has this much water and this much electrolytes. These two have the same amount of electrolytes, but let's call this B because it's on the right, and this is A. A has higher or lower concentration of water, electrolytes. Lower concentration. The amount is the same, but the concentration is less because it's diluted. So you have more water, less electrolytes. That's low concentration. It's not concentrated. But this is pretty concentrated, like this. B is very concentrated. So the amount didn't change. Just notice what changed: the water. And what does the antitryptic hormone do? It gets water inside. So in which case, and this is, by the way, is hypoosmolar because it's less concentrated. Osmolarity is the concentration. So if it's hypoosmolar, hypo concentration, less concentration. This is hyper or increased, hypo or decreased. So in which scenario will ADH go out to bring more water in? Obviously B. You wouldn't even think twice about it because you need more water. So hyperosmolarity or increased osmolarity or increased electrolyte concentration will get more ADH, and ADH will get more water to increase the water, to get the osmolarity back to normal, concentration back to normal. What if there is actually hypoosmolarity, more water, less electrolytes? Then ADH will be inhibited. طيب, how? There are like sensors in the hypothalamus that will sense the osmolarity. If it's high, it will send ADH out. If it's low, it will stop ADH from going out. Look, decreased osmolarity. So I just explained it to you. Now, decrease in decrease in blood pressure. Blood pressure is very important. Blood pressure is more important than osmolarity, by the way. So if the blood pressure is low, you want to get more water to increase the pressure. You took this in CVP, right? More water inside, increase the blood pressure. So if the blood pressure is low, you increase it. If the blood pressure is high, you decrease ADH. It's right here. Hypervolemia or increased blood pressure, it will inhibit ADH. Hypovolemia or low blood pressure, it will increase ADH. So it's increase, it's decrease. Okay, and this is the details like baroreceptor, vagus, you took in CAP. You will not be asked about it. Just know that decreased blood pressure. Sometimes you will get a question that's tricky. Look at this question. What if you have, let me think of a question. Okay. You have high osmolarity, okay, and high blood pressure. So the blood pressure is very high, and the concentration of electrolytes is even high, very, very high. Will ADH go out or no? So let me tell you this: increase osmolarity and increase blood pressure. Will ADH be stimulated or inhibited? You will say, oh, increased osmolarity, it means you need to reduce the osmolarity to increase the water, dilute the serum more, so will activate ADH. Well, no. The blood pressure in that case is more important. The blood pressure regulation is more important than the osmolarity regulation. That's why I told you, even when the osmolarity is increased, hypervolemia or increased blood pressure will inhibit ADH. Guys, you have to take care of blood pressure more than the osmolarity. Osmolarity can be fixed other ways, but blood pressure is extremely important. So that in that way, this scenario will inhibit ADH. Very important. You will get this question in the exam. I'm telling you, you will. The opposite. What if there's less osmolarity, very, very low osmolarity, like in scenario number letter A, and there is low blood pressure? Will ADH go out or no? Well, you will say, oh, there is no concentration of sodium and other electrolytes, so if we push out ADH will get more water. This will be even less osmolarity. Yes, but the blood pressure is more important. So in that scenario number 2, which is low osmolarity, low blood pressure, ADH will be stimulated. Blood pressure is the number one important thing for ADH. Okay. So here hypovolemia, it will stimulate ADH. As I told you, low blood pressure, even when osmolarity is decreased. Pain, nausea, hypoglycemia, get some drugs. Angiotensin 2, because angiotensin 2 is trying to increase the blood pressure, so it will activate ADH. ANP is anti-natriuresis peptide. It is to decrease the blood pressure, so it will inhibit ADH to decrease the blood pressure. Ethanol, it relaxes the person, so decrease blood pressure by decreasing ADH. Alpha adrenergic agonist, because it has its own actions. It's actually unclear. Like I looked it up yesterday, it's not very clear what action does it do, but it's vasoconstriction. So I'm assuming it doesn't need ADH to be out because ADH also has vasoconstriction. Okay, but the most important thing are number 1, 2, and here number 1 and 3. These are the most important things you need to know. The actions, as I told you, it increases water permeability through V2 receptor in the kidney, in the collecting ducts and the tubules to increase aquaporin 2. Aquaporin to absorb more water. This is through GS protein and CAMP. And it also has vasoconstriction through V1. So for the vasoconstriction, V1 through GQ protein to do what? Increase the blood pressure. I told you the number 1 importance for ADH is blood pressure. Increase water permeability also to increase blood pressure. So now you have an idea. Okay. Diabetes insipidus now. Insipidus, sorry. Diabetes insipidus is not like your like the one you know, mellitus. That's mellitus, which is the hyperglycemia problem. This one is another problem. Let's look at it. So you have low ADH. That is the problem. Why? Because it's a hypothalamus issue. The hypothalamus is not functioning right. ADH will be low. Why is ADH low? Hypothalamus. What will happen if ADH is low? You will have something called diabetes insipidus, and diabetes insipidus present as what? I want you to think what will it present with. I explained to you what is the action of ADH. Now imagine there is no ADH. What will happen? So, you know what? Let me remove this. Low ADH. I will take you step by step. So if there is no ADH, then the kidney will do what? The kidney will keep throwing water out because this is the duct. There is no aquaporins. There is no ADH. The water will increase in the kidney. In the urine, in ducts, and will all be always excreted. So water in the urine means what? More water in the urine. Diluted urine. See, I'm going with you step by step. Diluted urine. Okay, what about the blood? The blood is losing water, so it's concentrated. So hyperosmolar serum, or low water in the serum, or like high Na concentration and electrolyte concentration in the serum. So serum is concentrated now. The serum is your blood. Okay, this is what happens. Now let's look. Oh, that's what I said. Diluted urine, because more water is getting excreted. Increased serum osmolarity, which is exactly what I told you. More concentration, and the Na concentration I told you about. See, I didn't have to memorize this. I just thought about what will happen if ADH is low, right? Now we have two things: central diabetes insipidus and nephrogenic diabetes insipidus. So, hypothalamus, if it's dysfunctioning, there is no ADH. So no ADH. This presentation. What if there is ADH, but the problem is in this receptor in V1 and V2? If V1 and V2 receptor, this is V1 and V2, if they have a problem and they're not there, then ADH will be increased and this will be presented. So diabetes insipidus in both ways will have the same presentation, but one, you will measure the patient. You're a doctor, okay? You'll measure the patient. He has high or low ADH. If he has low ADH, then you know the hypothalamus is not secreting it. But if he's a high ADH and this presentation, then there is a problem in the receptors that are working. Very cool, very cool. I love this. So central, there's posterior pituitary problem and hypothalamus. Low ADH, you treat it by giving ADH supplements or the analog, like something that acts like ADH. What about if the problem is in V2? What will happen? V2 receptor problem, you will have high ADH, but it's unresponsive. No one is responding. Like, oh, ADH is there, knock, 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 knock. There is no receptor. There is no receptor. What is the receptor? It's not there. No receptor. ADH is there trying to do its job, but it's not there. It's high in the blood. That's how you know. It's very cool. SubhanAllah. Treatment here is different. You don't give ADH supplements because this man doesn't have a problem in ADH. He has a problem in receptors. So thiazide diuretics, even though it's diuretic, and diuretic means to push more blood out, push more water out, but the thiazide diuretics work by pushing sodium out. So my assumption, because I researched this yesterday, and like people say the mechanism is not very clear, but by trials they saw that thiazide diuretics, it works for diabetes insipidus, nephrogenic, by decreasing some osmolarity in the serum, so it like makes things slightly better. It's not like the best thing, but kind of works. I've done my research. Honestly, I didn't find like a very satisfying answer. So I guess I just wrote anterior mechanism. I guess just decrease the osmolarity of the blood. So instead of increasing the water in blood, it decreases the osmolarity. You still have other problems, but I mean, you go to a doctor. He will inshallah help you. I'm not saying you get this. Inshallah, you won't get this. It doesn't sound right. Nice. So difference is the ADH here and here, and the treatment, of course, because this has no ADH to give ADH. This has yes ADH. You don't give ADH. You give something else. So what is sayad? What does that mean? What does that mean? Okay. It means syndrome of inappropriate ADH. Why inappropriate? Because imagine this. In the lung, imagine there is a cancer or a tumor that rises, and this tumor secretes ADH. What? Yeah, it secretes ADH. It's old cell carcinoma, and it happens because of smoking, by the way. So be careful. It's like number one risk factor is smoking for the old cell carcinoma in the lung. This carcinoma has a property, it differentiates to be able to secrete ADH. And what did we say about high ADH in the blood? That's exactly what you will find. High ADH will cause, okay, let's do it together. Renal tubule, and there is high ADH. So the receptors will all be there, and the ADH will keep stimulating more receptors. So the kidney and the tract will get more water into the blood. This is the bloodstream. This is the blood because of blood cells. Will get more water here, less water there. What will happen to the urine? Urine will be very concentrated because it has less water, so it's hyperosmolar. I'll just write hyper. What about serum? Serum, which is the blood, will have more water. I'll write W for water. W also for you guys, because you're all W's. You're all amazing. And it will be hypoosmolar, low concentration. As I told you, this is the jar. It has high water. This is another jar. So in this case, this is the kidney, and this is the serum. Let's look if I'm right or not. This is the way I thought about it. This is the way I understand it. Decreased, let me just remove what I said. Decreased serum osmolarity and low sodium concentration. Here, concentration. So I'm right. And what about the urine? Increased urine osmolarity and higher sodium excretion or concentration. Why? Because of ADH. Now, we're done about ADH. Let's talk about oxytocin. As I told you, it stimulates. What stimulates oxytocin? So this is the breast. Suckling reflex. There is a nerve. Takes the suckling reflex to the hypothalamus to increase oxytocin. To do what? As I told you, the myoepithelial cells. It's a duct. To push and eject milk. Cervix dilation. When the cervix is dilated or stressed, it will send oxytocin. Oxytocin will come down, will contract more until childbirth is done. Now this is actually true. Sound, sight, smell of an infant. Women, when they like experience this infant feelings, sight, sound, smell, they might eject milk. It happens. I don't know if like it happens very common or not very common. I don't have much details, but this is like I've read the books. Like in steps, it said sound, smell, sight. It does stimulate milk ejection. Labor, I told you why labor, because of cervix dilation. Orgasm, it's just there, so I just put it. I'm not sure. I think it's also cervix dilation. I'm not sure. How do you inhibit it? Opioids or like things anti-pain, painkillers, but endorphins or opioid type. You don't need to know much about it because you don't know much about it. Like you will take opioids in neuro, inshallah, not now. So what are the actions? We said milk ejection. Myoepithelial cells lining the ducts will contract and eject uterine contraction, and it also reduces postpartum bleeding, and this is very important. Remember, postpartum bleeding, Sheehan syndrome. So less blood, less perfusion to the pituitary, infarction. So oxytocin actually helps in reducing the chances of Sheehan syndrome. And that's it. Thank you so much. And if you have any questions, reach me out. Don't hesitate. I put my contact in the first slide. Another thing is that, like, I hope I made some interactions. This is a pre-recorded, so it was a bit weird experience, but it's still, inshallah, it's helping you guys. And inshallah everything is helpful. If you have any questions, as I said, never hesitate to reach me out, and thank you so much. Salam.